Okay, it's 3:03, so I'm going to go ahead and start talking. It's always kind of strange doing these Zoom meetings because there's a lot of people on the other end, but you can't see the faces. But to everyone out there, I hope you're all doing well. I hope you're all safe, and I hope you're staying negative, so to speak. I want to welcome you to the American Society of Pediatric Otolaryngology and the American Bronchoesophagological Association. I'm going to be your moderator for this event. I'm Romaine Johnson. I'm chair of the ABEA's Community Outreach Committee, as well as chair of ASPO's Quality and Safety Committee. We got a great program for you today. We're going to talk about quality and safety in pediatric ENT. I'm an associate professor of pediatric otolaryngology and the medical director of the airway management program at UT Southwestern in Dallas, Texas. I'm going to introduce our all-star panel. We have Dr. Soham Roy, Dr. Jennifer Lavin, and Dr. Jonathan Ida. Dr. Roy is a professor and vice chairman of otolaryngology at the University of Texas at Houston. He is the incoming chair of the Patient Safety and Quality Improvement Committee for the American Academy of Otolaryngology. Dr. Roy is an international surgical expert in operating room fires and safety, and is an integral physician leader with both the FDA and Joint Commission committees on surgical fires. He's also obtaining his master's degree in medical management at the Carnegie Mellon University. Dr. Lavin is an assistant professor of pediatric otolaryngology at Northwestern University Children's Hospital in Chicago. She holds a master's degree of science in healthcare quality and patient safety from Northwestern. She serves as the director of quality and safety for the Division of Pediatric Otolaryngology. She's a member of the Button Battery Task Force, the NISQIT P-ENT Task Force, the ASPO Quality and Safety Committee, and the American Academy of Otolaryngology's Infectious Disease Committee. Dr. Jonathan Ida is an assistant professor of pediatric otolaryngology at Northwestern University and Lurie's Children's Hospital in Chicago. He's a medical director of the Aerodigestive program and serves as the vice chair for procedural services, supporting and leading numerous process quality and safety initiatives for the Department of Surgery. He's authored numerous papers on quality improvement in otolaryngology and surgical services, and he's also a member of the ABEA's Community Outreach Committee. Before we get started with our first speaker, who will be Dr. Lavin, I want to thank the ABEA and ASPO for hosting this program and give a special thanks to Drs. Karen Zur and Diego Preciado, the current presidents of ASPO and the ABEA, in support of this endeavor. Also want to thank Ms. Charlotte Grill, Ms. Elizabeth O'Keefe, and Ms. Corinne Marconi for their outstanding contributions to get this program scheduled. Just a few quick housekeeping issue. The program should last about an hour. It will be recorded for later viewing. If you have any questions, please post them in the chat. And so without further delay, I will have our first speaker, Dr. Lavin.
Great. Thank you, everyone. I'm just going to pull up my slides. All right. So I wanted to discuss, I'm Jennifer Lavin. I was going to discuss the basic principles of patient safety quality improvement. I do a lot of quality improvement work at Lurie, and this is just basically what I've found to be very helpful as I proceed. And so why, as otolaryngologists, should we do PSQI? And really the fact is that we interface as otolaryngologists with multiple different settings and multiple different services, which leaves us very well poised to do QI. And sometimes this really involves getting down into the weeds and sort of into the details of the system to make things better through things like process improvement. And I want to discuss a few key principles when I do those projects with you today. So the first principle that I wanted to go over is you need to make sure that you accurately identify the problem. Often these problems are right in front of you. Sometimes you can identify them from things like quality dashboards or say your NISQIP report or things like that. But other times it's really those issues that everyone knows exists, but we've just kind of tolerated and put up with over time. And so, that's a good place to start. When you select a problem, you really are going to gain the most traction if the problem that you want to solve is something that is within the kind of the 5-year goal or the fiscal year plan of your institution. You're going to be more likely to get executive support and resources if you can find some way to make it within the goals of your institution. In principle number 2, you want to make sure that you adequately study the problem. And, I always say, as surgeons, we like to solve things, we like to fix things. And this is very advantageous when speaking about QI. But sort of on the other end of that, as surgeons, we're often used to rapid decision making under pressure, which can sometimes work against you, because if you are not getting to the actual root cause of the problem and not fully understanding the full nature of the problem and just implementing a solution, you risk creating workarounds or further complexity in the system, which actually makes things worse. And so you do need to take a step back, and instead of jumping immediately to the solution, you need to, do things like you need to pull EMR data, study the problem through your internal review. Actually conduct interviews of multiple different members of the care team. Don't just speak to your service, speak to, other services. For example, for pediatric otolaryngology, a lot of times you end up speaking to the pediatric ICU or the neonatal ICU, or pediatric surgery or other fields. You may even want to reach beyond clinicians and actually speak to pharmacists, sometimes even just other ancillary staff, schedulers, etc. And then you want to, again, get all members of the care team. So nurses, ancillary staff, point of service, schedulers, everyone who kind of lays hands on the problem, to really kind of understand your pain points. I want to give an example of how I actually did not practice what I preached. And so what we did at Lurie, so this is a project where we're trying to streamline the diagnosis of patients who ingest coin-shaped foreign bodies, and try to determine whether it's a coin or a button battery. And along those steps in the way, one of the things that we did was we looked at the time from patient arrival to X-ray completion, and we were trying to improve that time. And we made the assumption that, of course, the problem was the fact that all orders in the ED are ordered stat, and that the button battery or the X-ray to rule out a button battery was being lost in the queue. And so what we did was we implemented a page to the technologist to let them know that they needed to move things up in the queue. And we figured that would fix our problem. But if you can see here on this control chart, when we implemented the tech page, we did not actually notice any change in the system. It was only at that point that we sat down and did what we probably should have done initially, which is sit down with the X-ray tech and say, what is your workflow? Let's map out the process to figure out, what goes into getting these films from the time of order. And what we found was several inefficiencies in the system. And it was only after addressing those inefficiencies did we actually demonstrate a change. And so this is an example, again, had we adequately studied the problem in the first place, we would have solved it much sooner. As far as the third principle is concerned, you need to make sure that you spend time designing your intervention. So for large scale PI and QI projects, this intervention is not something that happens quickly. I want you to think on the order of months to even years, not days to weeks. I can't tell you how many times I've started a project, come up with an intervention, and in my mind, I'm like, well, and it's practically already done. This will be easy. But keep in mind that hospitals are kind of like giant trains, and getting the train to stop and change course actually takes a lot of effort and a lot of time. And so be very, very patient with this. The other thing that you want to do is make sure that you're using an actual QI methodology. You want to be very systematic with your approach. It doesn't matter what methodology you use. There's a bunch out there. There's DMAIC, there's Six Sigma, there's the model for improvement, which some people call PDSA. It doesn't matter what you use, just pick something and stick with it. Next, kind of similar to, the on-the-ground interviews that, you're conducting when you are on the front end understanding the problem, you want to create a multidisciplinary team of stakeholders. And, this serves two purposes. The one purpose is, again, you can fully understand the problem, you can fully understand the solution and make sure that you're implementing a proper solution. But it also helps create buy-in because you're getting these people in on the creation of the solution. And it helps them, help adopt the interventions that you create. The last thing with, as far as designing the intervention that I want to talk about is you want to sometimes consider implementing simultaneous interventions because sometimes this redundancy ensures success. So for example, one of the things that we do at Lurie is we create clinical care guidelines to try to standardize our practice. We don't just create an algorithm that we then hand to people and expect that, you know, it will eventually be followed or that it'll be followed. What we do is we also then hardwire that algorithm into automated order sets. We create standardized discharge instructions, et cetera. And so you have, you know, many steps along the way that encourages and actually makes it hard work to deviate from the algorithm. And again, that helps make things happen. As far as principle number 4, you need to make sure that you are actually measuring the results of your intervention. And I know this seems obvious, but despite that, I can't tell you how often we implement change and just assume that improvement will follow, but don't follow up on that. And so you need to make sure you have a detailed measurement plan. Okay, and your measurement plan should also include your outcomes, processes, and balancing measures. Okay, for those who are not as experienced with QI, an outcome measure is what you're aiming to achieve. So this is like your, you know, say I'm aiming to shorten length of stay or reduce surgical site infections, you know, et cetera. And so that's sort of your endpoint. The process measures your, you know, interventions and all the sort of intermediate steps along the way. And so, for example, if I create an order set as my intervention, you know, and I think that that's going to lead to a decreased length of stay, for example, I want to measure how often the order set is actually being utilized. Because if it's not being utilized at all and you change your outcome, it wasn't because of the order set. Similar to that is, you know, completion of tests is another way to measure process measures. And so say you create an algorithm and as part of the algorithm, you recommend, you know, a regular screening for something. If, you know, the process measure would be looking at how often the screening test is performed. The last type of measure is your balancing measure. And these are the measures that measure unintended consequences. And so these are the things that you have to think to yourself, if I implement this intervention, what could possibly go wrong? How can things deviate from, you know, how could the pendulum swing the other way? And the reason that this is important is because sometimes your unintended consequences can actually be so great that even if your intervention is successful, it is actually not worth continuing because it creates a problem on the other end. And so that's something that you need to really kind of brainstorm and think about. I do want to spend some time talking about, when we talk about measurement, about also how we report out measures in QI. And so I want to talk about the importance of looking at run charts and control charts, which is a graphical display of data over time. And so many of us are used to looking at statistics with our sort of before and after understanding. And so this is sort of a hypothetical example that someone published about cycle times. And so you have your cycle time before your change and your cycle time after your change. And then you do your traditional statistical analysis on this. And you conclude that the change was associated with your intervention. This could also, but if you can also display it over time, and so you have your monthly average, you know, calculated, you know, each month. And in this first example, which could be created from the chart on the left, you can see that your intervention was implemented, and then after your intervention, you notice a change with a shift in practice down. But the same data could actually look like this. Okay, and so you can actually be having a gradual shift over time that preceded the intervention and had nothing to do with the intervention. And finally, you can have an intervention and then have the results look like this. And so initially you notice the change, but then you see a slow drift back to the median, which is something that we actually see frequently in QI. And so what we can say from here is that the change is not sustained. So you can see, since all of these three graphs can actually produce the graph on the left, it is actually better when you're talking about PSQI to really get used to using run charts and control charts to demonstrate your data. The last principle that I wanted to talk about was you need to be willing to challenge foundational assumptions and paradigms. Sometimes the biggest change occurs when we challenge the status quo. I want you to remember that reimbursement models are shifting from fee-for-service to value-based medicine, and the goals are really different in each. And this really opens the door to making very large changes in your system. Simultaneously, it can create some challenges because during that shift from fee-for-service to value-based medicine, there may be some competing goals. And so you may have to navigate that with your leadership, as you might have some short-term losses, but you need to make sure that you look beyond those losses and try to have forward thinking, or better yet, try to design an intervention that works in both systems and is advantageous in both systems. So I wanted to end with one example that kind of sums up all of these principles that we have done at Lurie. And so as a pediatric otolaryngologist, we know that there are this subset of patients undergoing adenotonsillectomy or other endoscopic airway cases with intervention, where there are clearly defined patients who are higher risk for having complications, specifically pertaining to the airway after surgery. However, even in this higher risk population, there's still a low percentage of patients who actually need ICU level care. And so there's really a lot of lack of clarity in our literature as to who truly needs to go to the intensive care unit. There have been multiple studies that have looked into this, and despite all of these studies and risk calculators, et cetera, there's really not been any additional clarity that has been achieved over time that really accurately predicts these patients. And so what we did was we challenged the status quo. We first studied our retrospective data so to fully understand the problem. And what we found was that most of our patients who actually utilized ICU resources declared that need within about 2 hours post-operatively. And so what we did was we designed a model of care where we had extended post-operative observation in the PACU, and where we made decisions at the end of that observation period based on the patient status. And this really challenged the paradigm that we have going into a surgical field, that all decision-making must happen pre-op. Well, really what we did was we said pre-op, they need to be risk stratified, but then they can be further risk stratified with final decision-making in the immediate post-op period. And so what happened when we did this? So we implemented this in July of 2017, and looking at fiscal year 2018, we called these patients gray zone patients because of their lack of clarity. And we observed 245 gray zone patients. And of those, 93.5% of them, or 229 patients, actually were able to be avoided to have a PICU bed. And the average time that was spent in the PACU was 2 hours, which is basically amounts to 1 additional hour in the PACU. We also, as far as safety measures, had no codes in the PACU, no CAT activations in the observation unit, and no secondary transfers to the PICU. So we demonstrated that this model was safe. As far as the financial implications of this model, we estimated that it resulted in $1.1 million in cost savings for the fiscal year. As far as other measures that we looked at, one of the things we looked at is unanticipated ICU admissions. Unanticipated ICU admissions are a marker of safety. And so you want to make sure that it's a marker of whether or not you're accurately predicting your population. And you can see, so we first did some internal changes, which are sort of out of the scope of the discussion today, that were not effective. But when we created the gray zone model of care, you could see there was a shift downward in unanticipated ICU admissions. Similarly with ICU bed requests, so this is the patient where you reserve a bed and cancel it, that becomes disruptive, and it is in its own self a waste of resources. Our internal changes actually were associated with an increase in cancellation of beds, but that was corrected upon creating the gray zone model of care. So breaking this down, this model wouldn't have existed if the problem really weren't adequately identified or studied. It wouldn't exist if we didn't challenge foundational assumptions. And finally, it was the measurement of our data that helped demonstrate the actual impact of our change, which then got us additional support to continue the model from our leadership. So in conclusion, otolaryngologists are very well poised for PI and QI due to the fact that they interface with multiple different settings. But you have to be deliberate about your methods in order to successfully demonstrate change and success. Finally, again, don't accept everything as truth. You want to make sure you challenge your assumptions, again, because this will sometimes lead to you gaining the most ground and having the most success. I'd like to thank everyone, and I'm going to hand it off to Dr. Ida, who is going to talk about QI in the era of COVID.
Thank you, Dr. Lavin.
Share my screen.
All right, so hopefully everyone isn't sick at this point of talking about fill in the blank in the COVID era, because that's what we're going to do today. But the reason we're doing it is because if everyone, this is a great opportunity right now to reflect on what QI meant during that period, how we were utilizing QI principles on the fly in short order with very little information to figure out how we were going to run a healthcare enterprise with no information. So we go back to last February, March. I don't need to set the stage really for everyone. Everyone lived through it. We had this new virus. It behaves differently for all that we knew. It was more contagious than any respiratory illness in any of our lifetimes. Severe infections in younger ages than any of us had ever seen, or at least that's what we were being told. There was a lot of uncertainty about how to treat this, about the death rate, about a lot of things regarding the virus. Then it hits the US and we have the New York City experience where there are staffing shortages, there are PPE shortages. We're hearing about our colleagues in otolaryngology being pulled into the PICU to staff patients in the PICU because of staffing shortages. And then of course we didn't have reliable tests. At the point, we did not have widespread reliable testing for this. So we were at a major disadvantage. Factor then in that we had a whole lot of information and misinformation flying around at that time. Much of it was hearsay and anecdote. And although for a great example was the Stanford paper, I think everybody's familiar with that paper that came out of Stanford. It was great information because it got conversations started. The problem with it was not anything scientific. It did not have any true data behind it, but it helped us have those conversations within all of our institutions. The New England Journal of Medicine was bringing out let's just say not fully baked papers on a daily basis coming out with information. And it was information that was necessary at the time, but it had limited utility because it was not scientific data. Remember that whole thing about ibuprofen. It spread like wildfire that patients who were on ibuprofen did more poorly than patients who didn't get ibuprofen. And that was very quickly proven incorrect and retracted. However, that rumors stayed around for months. And then we had government agencies and healthcare administrations instituting policies without data. So it was a very confusing time. It was like being lost in a strange woods with direct signs pointing in every direction. We really had no idea what to do at that point. So when you're lost in the woods and you don't know where to go, who else would you turn to but former Secretary of Defense Donald Rumsfeld? Stay with me here. So if everybody recalls, at one point, Donald Rumsfeld was asked about the lack of weapons of mass destruction in Iraq that would have justified the war. And he responded with a QI parameters. As we know, there are known knowns. There are things we know we know. We also know there are known unknowns, that is to say, we know there are some things we don't know, but there are also unknown unknowns, the ones we don't know we don't know. And if one looks throughout the history of our country and other free countries, it is the latter category that tends to be difficult. So that's really wise because it basically puts a framework around what we know and what we don't know and what it means for us. So if we grid out his comments, here we have our known knowns grid. On the y-axis, we have awareness of the information. And on the x-axis, we have the actual availability of the information, whether the knowledge is there anywhere. If we were to define those, this is sort of how we would define it based on his quote. And if I were to add some sort of value statements to that, our known knowns are absolute certainty. We have a respiratory virus that travels through aerosol droplets. The unknown unknowns are complete uncertainty. We have absolutely no idea what we should be looking for. The known knowns, things that we know that we don't know and that we need to find out. We need to get a good test. We need to make sure that that test is good. We need to figure out how we're going to handle moving people around, et.cetera. And then unknown knowns, there is information out there. There was information in China that we didn't have access to yet. And that's where these papers that were coming in that weren't necessarily scientific, it was useful information for us in the unknown knowns realm. But the problem was there were a lot of unknowns. So what did we do? We shut it down. Everything stopped unless it absolutely had to go. We shut everything down until we can gather our information and put together a framework by which we could then decide what our priorities were and how we were going to approach them and how we were going to study them. So here we have a basic framework of a quality improvement process. We defined our outcomes. We wanted to prevent infections and preserve PPEs at the outset. So that we established our processes, we have testing algorithms, and we have interventions for transmission prevention. And then we introduced our interventions. We put on masks, we started daily symptom checks, social distancing, limiting traffic in and out of the institutions, viral testing, select PPE usage, limiting our PPE usage. And then we studied it. We studied our infection rates. Were there outbreaks within our institutions? How was our PPE usage going? What were our PPE levels available? What are our testing resources available? Were we running out of tests? I would actually, if I could go back when I was making this, I would actually also add in the study bubble frontline staff perspectives, because I think that was an important thing that administrations were really trying to keep a pulse on. What was the response from their frontline staff? And then you evaluate your data, you refine and adjust accordingly. And once you feel like you're meeting your defined outcomes, then you choose your next defined or desired outcome. For example, starting elective surgeries in ambulatory practices. Have we gotten to the point where we can do that? And if so, how do we do that? And then we just go through that quality improvement process that Dr. Lavin defined so nicely earlier, to see that we have successfully accomplished what we need to do to continue our practice and start opening up our institutions again. Now, we're in a privileged position in otolaryngology to evaluate the outcome of one specific area with regard to this process over the last 9 or 10 months, and that is airway management. We deal with the airway every single day, and it is one of really the high risk area when it comes to coronavirus transmission. And we can now look at where we are to see how we got to the point where we are with airway management and where we are with sort of current best practices, if we could even call it that at this point. But there were so many critical questions regarding PPE usage and transmission risk when it came to airway management. Obviously, the major question was, what is a high-risk AGP? Many institutions were defining high-risk AGPs as starting at the vocal cords and beyond and nothing else. But us as otolaryngologists, and knowing that viruses tend to live highly in the nose and nasopharynx, that leaves out nasal and nasopharyngeal instrumentation. What about oral and dental procedures? What about drilling a mastoid? So there were a lot of questions about what a high-risk AGP was, and depending on your role in an institution, you probably had a certain perspective on it. There were also questions about which procedures are critical and which can be postponed. When Illinois went into lockdown, I was actually our inpatient on-service surgeon, and I remember getting a call from our cardiac colleagues about a patient who had had a heart surgery, who was hoarse, had a video swallow, was swallowing fine, and they asked us if we would come by and do a laryngoscopy to see if the vocal cord was moving. And I said he was swallowing fine. They said yes, and I said, we'll see them in a few months. You know, it was making that choice of whether we were going to do the risky procedure with all our PPE in a patient that we probably weren't going to institute any kind of intervention anyway, once we knew their swallowing was fine. So what can be postponed? What can be substituted? We did a lot of substituting of video swallow studies for FEES exams, as long as there weren't airway problems that needed to be evaluated, obviously. What other safety measures could be put in place over the last few months that would allow us to get back to our regular airway practices that we believe do serve the patients best? For example, a great example are the air filtration systems that are all over the place, and that you basically can't get a HEPA filter right now because they're so far on back order at the moment. Another major question, and I know this has been going on across institutions across the country, people have been talking about this issue, is tracheostomy patients. What do we do with tracheostomy patients? I mean, these kids are beyond high risk for aerosolization. It's like a superhighway for aerosolization. So how do we manage them? Is having an HME enough? Should they be tested? Should they be categorically tested before they come to a clinic appointment? And what about vents? Do those increase their risk of aerosolization? And if they do, does an inflated cuff then reduce or eliminate that risk? Again, these are all known unknowns that we really don't have particularly good answers for. A part of the problem here with all these questions is that we are in a healthcare system in the United States where we do not have sort of a top-down policy directive. There may be other countries where there are that, such as the British national healthcare system, but we don't have that. So these questions were all being decided locally. In the extensive conversations that we've all had over the last several months, it seems that for the most part, institutions were on a fairly consistent path, but with some variation. But there were definitely some consistent themes. And I chose to break these down into elective airway management versus emergent or urgent airway management. Obviously, elective is a lot easier. You get the opportunity to test people and to follow guidelines. We trust the test. I actually looked it up. The CDC stopped tracking how many tests were being done in August of 2020. And at that point, there had been almost 80 million done already. And by this point, it has to be in the multiple hundreds of millions in the US alone. So the test has been done a lot and it's been well refined. So we have a good test. And then we have the opportunity to do all the procedure enabling that we need. We need to make sure that it's the right patient, that we're doing it for the right reasons, that we have the right space, that we're doing it in a place that minimizes risk, and that we have the right wraparound measures to make sure that we're minimizing exposures and minimizing risk. Obviously, it gets a lot more complicated in the emergent or urgent scenario. Rapid testing was a potential option. If your institution is like mine, you recently went from a rapid option to a not quite as rapid option. We used to have a rapid test that was about 90 minutes. Now we're at a rapid test that's about 3 hours. So that option has kind of dropped off, but we've also gotten better overall at figuring out how to take care of these patients. Multilateral decision-making with open communication among all stakeholders with what's going to happen with that patient and the people that are going to be exposed to that patient, along with a risk analysis. If it's truly emergent, obviously you have to go, you use your PPEs, you use your negative pressure room, etc. And then, of course, once you've decided to go ahead and do a procedure on a patient who either is COVID positive or is a person under investigation who you don't know their status, minimizing potential exposure becomes the key. Limiting bag mask ventilation, limiting how much operation is done on the airway to limit how much aerosol exposure there is, minimizing procedural time to get everybody out of there as quickly as possible. And then one thing I wanted to tag on here that I think I've found extremely important over the last few months is remembering the support staff. Over the last few months, I've noticed that, of course, the anesthesiologists and the surgeons and the physicians are well empowered to speak up about how they feel about the current situation and that immediate situation dealing with an emergent COVID positive or PUI patient. But our support staff oftentimes will not speak up regardless of how they feel. And so I have found it very helpful over the last few months to solicit from them their thoughts about the upcoming situation and help to advocate for them and for what we're trying to do in the OR. For them. So now I want to pass it off to Dr. Roy.
Thank you. And thank you so much for having me on this panel. Thanks to ASPO and ABEA. Special thanks to Romaine for making me follow 2 brilliant talks. That's never a fun position to be in. Most of all, I think the really cool thing is I'm looking at the list of attendees. And not only is it a who's who in otolaryngology, but it's like seeing a list of all my friends. And so it's really cool just to see all these names on the chat box. Hello to everybody. I'm honored to be here. Let me try to share my screen here. Okay, great. Let's see. Hopefully you can all see my screen here. Okay, so this is the part of my talk that I call Leadership in Quality and Safety. Romaine asked me to speak a little bit about my leadership journey. And as I was trying to figure out how to put this together, I realized the only way I can describe it is that dumb luck is sometimes better than no luck at all. And how do you begin your journey in quality and safety? And there are a couple of different pathways to do this. So Dr. Lavin did a formal master's degree coming out of her training and got really formalized training. I am too old to have done that. It didn't exist when I started training. I had a bad experience. And a lot of sometimes, as people always say, that experience comes from, judgment comes from experience. The problem is a lot of that experience comes from bad judgment. In my case, I actually had a bad experience that may have been a little bit related to being a sociopath. But what happened to me was I almost hurt a child. And I was just a year or two out of fellowship, and I was doing an endoscopic airway surgery. And a light cable melted a hole in a drape, and you can see the picture at the bottom of the screen here. And the patient would have been terribly burned, except that we'd already moved them onto the stretcher and rolled them out of the room. Well, this got me thinking. And I said, okay, is this a known phenomenon? Is this something somebody has studied and decided to make better? So I started looking into the literature. And as I looked into the literature, it turns out that there was no data about burns from fiber optic cables. And there was, in fact, very limited data around fires in the operating room, and there was no good science behind it. And so what I saw was not just an opportunity, but in a sense, a moral obligation to start to study operating room fires and operating room burns. And this has taken me down this journey over 15 years or so through understanding surgical fire, surgical burns, and you know, a journey through quality and safety. So sometimes it's just dumb luck that takes you into this experience realm. And this has led to a lot of my original research. Anybody who's seen my talks on fire safety know that we got kind of famous for our chicken model, our organic chicken model, trying to understand, for example, in tonsillectomy, how fires can occur just from electrocautery in the presence of oxygen. Some of you may have seen this. This is one of my signature videos where we were doing a simulation of an airway fire that occurred out on the West Coast. And so I'm doing a laser airway surgery with a reinforced laser tube, but I can still ignite a fire. And we went through the process to understand how bad the damages could be. And you'll see here that I'm thinking that I'm in control. I'm going to mute this a little bit here. I'm thinking I'm in control of the situation and that I've put out the fire. But in fact, what you're actually going to see is the fire has propagated much further down the airway than I actually could even realize until our anesthesiologist very rightly uses the fire extinguisher, and I can glue my eyebrows back on. So this journey kind of started with just one bad experience and has led to running a lab and kind of going forward in my career with it. So, you know, Jennifer mentioned the Plan, Do, Study, Act model. In my case, I skipped planning entirely. I simply did a bad thing. I did a bad experience, and that forced me to study. And then we implemented change through the educational process. And so I skipped plan, but went to Do, Study, Act, and then we can continue that cycle as we study more and make changes according to that. So that over time led me to become the Director of Quality and Safety for my department. And over the years, I was then asked to lead the FDA and the Joint Commission subgroups on preventing surgical fires. And then for about 6 years, I ran what was called the Safer Use Initiative at the FDA, which was looking at improved surgical safety from a products and device perspective, and ran that committee for about 6 years. And I was on the ASPO PSQI committee, and now I've been named the chair-elect for the American Academy of Otolaryngology, which is incredibly stressful, and I can't tell you how incredibly stressed I am that I'm going to do a bad job at that job. But it's a real honor for me, and I'm looking forward to taking on that role. So you think, okay, you have this experience and then you build your career around quality and safety, even if you weren't fully expecting to. It turns out there are tons of stumbling blocks along the way. And I want to tell you about one of them. So I've run the FDA committee, I've run the Joint Commission committee, I'm going to be running the American Academy of Otolaryngology committee, but in my own children's hospital, where I work right now, I actually have almost no formal leadership role within my own children's hospital in quality and safety. And the reason for that is largely political. In fact, there are certain surgeons who work for a certain division who are given all of the committee assignments, and no one else, unless you work for that division, is allowed to participate in quality and safety within the children's hospital. And my favorite example of this is the Joint Commission dinged us for not having a fire safety protocol. Now, mind you, I was running the Joint Commission committee at the time. So I knew this was coming. I told everybody this was coming. And I said, listen, I run the committee. I can tell you exactly what we need to do. And they turned around instead and gave the project to a junior pediatric surgeon who had no experience whatsoever in surgical fire training. She went to the web, downloaded a bunch of stuff off of websites I had written, and then presented them at our surgical safety meeting. But the best part was I'm sitting in the surgical safety meeting, and then at the end of the meeting, she comes up to me and she says, hey, I hear you have some expertise in this area. Would you mind if I borrowed your slides for my talk? And I said, yeah, I'd mind very much. In fact, I don't think we're going to do that. So there are always these kinds of pitfalls, and your job is to sort of navigate around them. Now, meanwhile, in my own children's hospital, we've had a big push for improving our safety protocols. we went through this long production to develop this extremely lengthy checklist, which when you time it out, takes us more time to do our pre-op timeout for a set of ear tubes than it actually takes to do a set of ear tubes themselves. So we double our OR time for a set of ear tubes by doing our checklist. And thankfully, though, we have a really thorough checklist that we're paying attention to very carefully. I walked into my OR and found our surgical safety checklist on the floor, sitting sideways next to the patient roller. Well, that's helpful. And then at the same time, about a year ago, I walked into the OR. And, you know, the surgical safety director said, don't worry, we have this EMR and we've got all our checklists there. And I said, well, yeah, because clearly our EMR is going to help us when all it takes is a simple typo to screw up all of your weight-based dosing. This child was not 411 kilos. He was, in fact, 41 kilos. But boy, this can really screw up your dosing in the EMR system. And then sometimes you just walk in to the children's hospital, and this is what I find. Underneath the hand sanitizer, heparin with a needle and syringe sticking out of it. That, to me, is not safe care for children. And then one of my favorite stories, everybody who does airway surgery is familiar with this. This is plain lidocaine, right? We all know plain lidocaine because it's green, and we can use plain lidocaine topically in the airway. And we all know if you need to inject lidocaine for a skin incision, we use lidocaine with epi, which is red. This is lidocaine with epi. It says with epi 1 to 100,000. And then one day, with no warning whatsoever, I walked into the OR and I found this, a green bottle with a little red lettering. So now I don't know whether this is plain lidocaine or lidocaine with epi or some kind of hybrid. It turns out this is actually the same as this. They just repackaged it and didn't tell anybody about it. So these are the same medications in the same dose, in the same concentration, in the same amount. And nobody was given any warning. So people might think that they're getting plain lidocaine, but you're in fact about to inject lidocaine with epinephrine down the airway, which would be bad. So there are constant safety hazards. And what I've learned from this is that sometimes leadership in safety and quality is just recognizing a problem. And I think Dr. Lavin stated this very eloquently, which is just people know that these problems exist, but they just accept them. They haven't been willing to take them on. So I want to change gears and tell you a little bit about my tracheostomy journey, which is a good example of how you can engage people to acknowledge that these problems exist and actually try to make changes about them. And I call it from our train wreck to now what is a slightly slower train wreck. And for those of you who have ever seen the program This Is Us, it's on NBC. By the way, this show is terrible. Don't ever watch it. I actually broke up with a woman because she made me watch one episode of it. It's terrible. But this is my version of This Is Us. This is our children's hospital, which is the largest hospital system in the medical center. We're a big children's hospital. We're 310 beds. We're one of 4 level 4 NICUs. We're the first pediatric trauma center. We have a massive tertiary NICU with 118 level 4 beds. We've got a 50-something bed PICU and a very busy cardiac surgery problem. So we get a lot of tertiary and quaternary care. My first few years here, it was me and my partner who I hired to do pediatric otolaryngology, and there were 5 pediatric surgeons. Well, both of those volumes have increased significantly over the last few years. And what we found was, as we brought on new faculty, we were bringing in more variability because everybody has their own way of doing things. And so we went back to study our tracheostomies, and we found that we did about 193 tracheostomies over a study period, which was 91% of the trachs, and the pediatric surgeons did about 8 or 9% of the trachs in this institution. But this is also us, because during that time, we saw 5 accidental decannulations in the immediate postoperative period before the first change. One of them was a code event. We thankfully didn't have any deaths or anoxic brain injuries, but 2 kids had to go back to the OR unplanned. And there was a litany of horror stories around this, which I'll get into in a second. And this goes to where studying the problem can be very helpful, because if you look at Rahul Shah's paper with Emily Boss, it's a very famous paper looking into pediatric otolaryngology and where there's opportunity for quality improvement. So tracheostomy was the highest priority, kind of one of the simplest low-hanging fruit for quality improvement in interventions. Same thing for airway reconstruction, mastoidectomy and abscess drainage. And, you know, as Dr. Lavin pointed out, Dr. Ida pointed out, sometimes it's a matter of just recognizing where there's opportunity for improvement. And certainly tracheostomy is a big opportunity for improvement. So we saw an opportunity. So when we look at our walk of shame, we had 3 what we call totally unexplained decannulations, where kids magically decannulated themselves while they weren't being watched. One of them, the nurse decided to bathe the child. So she picked the kid up while she was still attached to the vent and then moved the child, and it just pulled the trach right out. One, we had an unsupervised resident doing the trach change and they couldn't replace it. We had a bunch of wound breakdowns and our variability was going out of control. There was no standardization. We didn't standardize our pre-op counseling with families, our post-op management. Every surgeon had a different preference for sedation. Surgeons were changing their trachs on different days. There was no standardized family teaching. There was no standardized discharge planning. This was resulting in significantly wasted resources and a bunch of frustrated families and frustrated physicians and staff. So we had to just devise a workflow and we had to standardize. What are we going to do preoperatively? What are we going to do intraoperatively? What are we going to do postoperatively? And what are we going to do for discharge planning? Now, as we've discussed, I think that's come up a couple times, part of it is getting buy-in. How do you get buy-in? You've got to show people that there's an opportunity for improvement and that this impacts patients' lives. And then, as Dr. Lavin also mentioned, a key part of this is getting the appropriate stakeholders. The appropriate stakeholders are not the faculty physicians. That is but one tiny element of it. Your real stakeholders are your ICU physicians, your nurses, your respiratory therapists, your social workers, the administrators, because these problems cost money. And then you develop your protocols around the best available evidence. And if you don't know what that evidence is, it's time to go to the literature and start studying. And then, as we've mentioned, tracking your results is critical, because if you're not actually measuring your results and making changes around them, you have no idea if you've made a meaningful impact at all. So we started developing our protocols around this. And this is just one example. This is our initial trach care sheet, which is posted with every patient. It's listed right there. So everybody knows we're going to do things in a standard way after all the stakeholders have agreed upon. And there's a tracheostomy handoff sheet in the post-op tracheostomy period. It says what day the trach was placed, why it was placed, who did it, what kind of tube, whether there's a cuff, whether there are stay sutures, what's the plan for the change, and what's the sedation plan. It kind of gives you an outline so everybody understands what we're going to do. And then some immediate post-op management issues about ties, sutures, x-ray, when the tube is going to be changed and things like that. Now, if these parameters that we're reviewing sound familiar, it's because all of these things, pressure ulcers, tube positioning, sutures, dressings, chest x-rays, these are the pediatric NSQIP protocol definitions from the American College of Surgeons. These are the things that the ACS NSQIP is actually tracking. So they've written out for you what they think is already important, and we can define what we need to follow based around what they've already defined as important. You don't have to try to reinvent the wheel here. So yeah, there are pitfalls in this. This took us 2 years to develop. And in those 2 years, you start to get mission creep and you get more and more stakeholders who want input in things that we've already changed 2 years ago. And then once you've got agreement, now you've got to get it through the hospital system. And it turns out, as I learned in my hospital system, once you develop a fully accepted policy, you have to go back to the policy on policies to make sure that your policy matches the policy on policies to get your policy into a policy. Yes, I said that correctly. So we have obstacles, but we also have victories. One of the simplest ones is in our EMR now, we have a simple checklist that goes through all of the post-op trach care. So when you perform a tracheostomy, this checklist comes up so that all of the post-op care management parameters are standardized. And what do you do from here? Well, some of these things don't have an evidence base, right? And I'll give you one example. I typically change my post-op baby trachs on day 5. And I have other partners who do it on day 7, and I have one partner who likes to do it on day 3. And none of us actually knew whether that was right or wrong. So what did we do? We've now gone back and we've studied all our different post-op day trach changes to look at the outcomes. And we actually just submitted that paper as a revision to the White Journal, I think. So I'm optimistic that'll be in print at some point soon. And then again, you can track your outcomes in relationship to variables that already exist. So in our case, we use NSQIP to look for accidental decannulations, wound breakdowns, and our placement afterwards. One other example, Dr. Lavin talked about run charts. I love run charts because they really give you a better sense of what's going on. When COVID first started, we have a separate COVID operating room, and our COVID operating room was a dumpster fire, quite frankly, because you could have a case, a simple abscess that was COVID positive, get the case done in 10 minutes, and then it took almost 300 minutes to turn the case over on certain occasions. And so we found out that it was just completely sucking up one of our operating rooms because there was such variability in the way that it was doing. So we plan, do, study, act, figured out where all the shortcomings were. Part of it was we didn't have an isolation room in PACU to recover a post-op patient. So a post-op COVID patient was being recovered in the operating room by the same team, and then taken back up to the room, which was taking hours out of the day. So we got a negative pressure isolation room, and that's our COVID recovery room. Patients go to the COVID recovery room, room gets its terminal clean with the UV lighting, and all of a sudden our turnover times, as you can see, post-intervention, have now been cut to a much smaller standard deviation and a much more reasonable 30-minute turnover time instead of 100 or 200. So these are examples of how that can work. And so I will summarize by saying this. Leadership in patient quality and safety certainly can involve study, and it can involve a formalized study project. I certainly have done a lot of formal study in it over the years when I wasn't planning on doing it initially, but it's really helped to study. But sometimes you just have to show the initiative. Find a problem that nobody's been willing to address and try to fix it. And sometimes part of that is finding a solution to a problem people didn't know they had. Like our COVID operating room. Nobody seemed to think this was a problem for 7 months until I run the OR Throughput and Efficiency Council. And I said, look, we can't waste this kind of OR time. Now people realize we have a problem and we found a solution to it. But I will say this, all of you who are on the call now or have joined, are going to join this call again in the future, the fact that you're here shows that you care about quality and you care about safety. And if you care about quality and safety, I think you're way ahead of the curve. Otolaryngology, as has been discussed already, is a really prime field to push quality and safety measurements, and a really good opportunity because we interface with so many other fields of medicine to improve the quality and safety landscape. So the fact that you're here puts you way ahead of the curve already. So I will stop there. Thank you all for listening and for joining. It's really nice to see everybody.
Thank you. Thank you to all the panelists. Wow, I'm blown away. So we have just a few more minutes left. I know everyone wants to get back, and it looks like Dr. Roy, you got to go do some more operating. But I just wanted to give a quick impression of some of the things that I learned today. So Dr. Lavin, again, I love your talks. They're always just so precise and just give me really good information and things that I can add to my own lectures. But the automation of orders was something that really struck with me. I don't think we do that enough at my home institutions. It just makes certain things automatic and not depend on someone clicking a button or a field with the mouse. Dr. Ida, I asked you to talk about Rumsfeld, Secretary of Defense Rumsfeld's famous quote, and that chart you put together, man, that was awesome because you put little markers underneath that said like, okay, I think this is what we mean by this is observation, this is exploration, this is kind of theorizing. And then Dr. Roy, as always, your talks are outstanding. It reminded me of a couple of things. One, it's not the stimulus, but the response. So it's not what happens to you, it's how you respond to it ultimately that determines the outcome. And so you had an event and you responded to it in an appropriate way to make things better. And then the other thing I will add is you quoted a paper from Dr. Boss. I'd like to say Dr. Jachana was also one of the authors, and I saw him on the line.
Hey, Chris, great paper.
And remember that if there's things with the NSQIP or any type of outcome measure or process measure that you don't like or you think is wrong, there's always somebody within our field or who we know that has influence over that who can change it. Like Dr. Lavin is on that committee as well. Hey, Dr. Lavin, I don't like the whole granulation tissue with trachs. That's just not a good outcome measure. Can you think about changing it? And next thing you know, we can get things changed. Anyway, we just have a few minutes left. I'll open it up to if you guys have any questions or you have any last, there's not really anybody asking any questions in the chat. If you all have anything to say, kind of last words, we're coming up on the end of the hour. I'll let you just go for it. I just blew you all away. You're all good.
So I think, gosh, if I can scroll back up here, Jenna asked about what should she be looking for in a fellowship to position herself towards a career in quality and safety?
Yes,
Me personally, I think the formalized training is extremely helpful. I did mine later than I think Dr. Lavin, Dr. Ida did. But just showing an initiative, showing that you care, I think that is the first step. And just paying attention to the issues is enough to drive you forward. And at the same time, getting formalized training can be very helpful.
And remember, most pediatric fellowships have quality and safety as a part of their training and in their curriculum. So you should get some exposure to quality and safety no matter what fellowship you choose to go to.
And talk to your quality and safety officer, at wherever program you're at, because I'm sure there's something that you can pick up as a project during your fellowship year.
And then oh, sorry, Dr. Ida, go.
I was actually going to ask a question since we have these panelists that are involved with NSQIP. Tracheitis as a complication of tracheostomy. For people in the audience who don't know, one of the complications, according to NSQIP, of tracheostomy is tracheitis. But tracheitis is defined as any kind of positive culture that is drawn out of a tracheostomy tube, even if the trachea itself is pristine. So I wanted to ask where that is, because I know that people on this panel were having those discussions with leadership at NSQIP.
I think, Dr. Jatana maybe could email you offline, but if I remember correctly, they were thinking about removing that because
it's still there for now. For now, it's still there.
Nebulous.
This is the one place where we've struggled because we get dinged on this all the time.
Yeah.
And I'm like, even if it's non-pathologic, if somebody gets a culture as a part of a fever workup, in a totally normal trachea, but it grows some colonization, that's going to count as tracheitis. So yeah, that's been a little bit of a sore spot. It hasn't changed.
But even the classification scheme for tracheostomy complications is very nondescript. It'll say infection of tracheostomy. Well, what is that? Or malfunction of the tracheostomy. What is that? That could be a mucus plug. That could be accidental decannulation. So there really, at some point, we do need to do a better job of defining what each one of these terms means, so we can all standardize our reporting.
And I think I think Chris is speaking up. It says still being debated. Yeah, it was definitely something we're pushing for. I know on the NSQIP end, a lot of pediatric NSQIP and even adult NSQIP, it's built off of the general surgery experience. And so how they define things often drives how things are defined for us. And sometimes it takes a little bit of time to kind of change those definitions to modify them to fit us.
I mean, I bring it up just because it gets to the point of what you said in your talk, Dr. Lavin, about making sure that you're measuring something meaningful. And that's a really big one. Every month we go to our safety meeting in the Department of Surgery, and there's one place where otolaryngology is like way up here with complications, way beyond it. It's tracheitis.
Although it's interesting though, because one of the things it has identified is an opportunity for stewardship in tracheal cultures. And so even though we're being dinged and we're frustrated from it, there is an opportunity as far as PSQI to look at it and be like, well, why are we doing so many cultures for colonized, and why are we treating so many people with antibiotics for colonized tracheas, and that in itself is a quality improvement project.
And remember the NSQIP, the purpose of it is really to generate quality improvement initiatives, not to ding you or punish you. We just had our big certification meeting, and they emphasize that over and over again. The idea is, how can we generate programs out of the data? And as Dr. Lavin said, if the whole tracheitis is, BS, then that's an initiative that you can take and say, look, we have to figure out a better way to do our cultures, our antibiotics. And then I wanted to mention, Dr. Thompson mentioned that don't forget QI and PI work can turn into scholarly publications. Case in point, Dr. Lavin. Anything else? Oh, another one that pops up, being on a vent 48 hours after trach when lots of kids are vent dependent. Interesting that would pop up. Have you guys seen that at your institution?
Because we always have them vented for probably.
Yeah, we keep them vented for a couple days.
Yeah. Or they're NICU patients who are vented for months, years.
Any is 401, any last?
Just one quick thing, Ricardo de Hoyos from Monterrey, Mexico. Hey, Ricardo, he asked, what's the best way to begin a safety and quality pediatric committee in a non-pediatric hospital? My vote would be get your stakeholders together. You don't have to go to the hospital and say, I'm going to start this committee and I need this time and this room and this funding. Get your stakeholders together. Get your handful of people of like mind who are interested in building that committee with you. Once you get that group of people together, settle on a time. You don't even need physical space anymore. Get them together on a virtual meeting like this and start talking about these issues. And then you'll start to develop your methodology and go forward from there. But you don't have to be in a dedicated children's hospital. You can absolutely, I'm in a children's hospital within a larger hospital system model. I'm not at a freestanding children's hospital. So it's absolutely doable in that same construct.
Okay, guys.
Alan Deutsch mentions, don't forget that you can test proposed improvements with simulation. That's 100% true. If anybody wants to come light some stuff on fire, come on by my lab. We'll burn some stuff.
Yes. And actually, speaking of simulation, I guess I'll go ahead and plug it too. I just saw an email saying if you have any simulators you want to submit to the Academy, you still have time. That's a great, and I guess there was someone mentioning joining a fellowship. That's a great part of the meeting. Knock on wood, it'll be live and in person, but going to that simulation seminar is always entertaining, seeing what people do. All right, everyone. I'm going to close it out. Thank you so much. Thank you to our panelists, Dr. Lavin, Dr. Ida, Dr. Roy. Thank you, Charlotte. Thank you, Elizabeth. Thank you, Corinne. Thank you to the audience, to the ABEA and ASPO. This is recorded, so it should be on the website soon. Please reach out and email us with any questions, and be safe, stay negative.